Thank you, Bob. Today I'd like to go over some of the concepts that relate to the definition of the meaning of a significant coronary artery lesion. And I'd like to explore the utility of some of the current non-invasive methods for detecting patients who are at risk for complications of ischemic disease. Have the slides on, please. Bob was absolutely right when he mentioned that ischemic heart disease is still the #1 killer of Americans. This hasn't changed in 1988. Roughly 54% of the deaths in the United States are due to cardiovascular diseases, and in particular myocardial infarction due to ischemic heart disease forms the bulk of that population. Now, what is a patient at risk for when he has ischemic heart disease? Well, we're all familiar with these dreaded endpoints. First and foremost is death. Next is non-fatal myocardial infarction. Many patients are at risk for malignant arrhythmias, which could lead to sudden death. There's a group of patients that will develop unstable angina requiring aggressive intervention, and patients with a more stable course of angina who will have a worsening of their symptoms. The question that I'd like to address is which patients are at greatest risk from coronary disease? Kind of the global answer to that question is those patients who will have large amounts of non-functioning myocardium after the next event. Now, it's well known and has been so for about 2 decades now that coronary anatomy relates to survival. It's been documented time and time again that patients with multi-vessel disease, for instance triple vessel disease, have a poorer survival over time than patients with single vessel disease. This anatomic stratification has formed the gold standard for all the non-invasive procedures that have followed over the past 10 to 15 years. It's also well recognized that there are problems with the angiographic analysis. One of the major problems is the variability in interpreting coronary angiograms. In one study, appeared in 1977, 10 coronary angiograms were read by 11 well-trained independent readers, and it was found that the average standard deviation of any segment stenosis by any reader was on the order of 18%. It was also found that in about a third of the time, the observers disagreed on even the number of involved vessels. This leads to a conclusion that hopefully we'll be convinced of at the end of the talk, that coronary artery disease, as determined by subjective anatomy, is not really equal to myocardial ischemia, which requires assessment, objective assessment of pathophysiology. Now, the concept of assessing the pathophysiologic significance of a coronary lesion is actually a fairly recent one. This is a slide from one of the first studies to address the issue. This appeared in 1974 by Lance Gould et al. And in this study, they took dogs to the cath lab, and they studied the response in coronary blood flow using electromagnetic flow meters around the vessel. They studied the response to hyperemia, and hyperemia was induced by injecting contrast media. They also had graded micrometers around the vessel, and they would slowly increase the degree of stenosis in the coronary vessels and examine the subsequent response to hyperemia. Some interesting results were found. First of all, at rest levels or basal levels of coronary blood flow, they found that only at very high levels of stenosis, approaching 85%, was there any decrement in coronary blood flow. Now, there is a clinical analog of this situation in that many patients can have fairly severe coronary artery disease and will be totally asymptomatic at rest. They also found that when hyperemia was induced, and they got an overall increase in resting blood flow of about 4 times basal levels, with hyperemia, they found that the decrease in the blood flow response, or the hyperemic response, occurred at much lower levels of stenosis. There appeared to be a downturn in the curve at about 40% stenosis. This concept of a limited reserve, limited vasodilator reserve, limited flow reserve, is the best definition of a physiologically significant coronary lesion, whatever the apparent anatomy is on angiography. This slide comes from a study that was done a few years ago using digital subtraction and angiography by Vogel et al. And they wanted to, first of all, improve on the variability in detecting the severity of stenosis. They used quantitative methods to assess percent stenosis. They also looked at the hyperemic response to get some measure of coronary vasodilator reserve. What they would do would be to look at the contrast arrival time in digital arteriograms. They would inject another bolus of contrast to cause the hyperemic response and then reassess the bolus arrival time. Of course, with vasodilatation, the bolus will arrive at the distal vessels in a shorter period. This was interpreted to reflect the vasodilator potential in the vessel. They found some interesting results. If there was no stenosis, routinely there was at least a 2-fold increase in coronary flow, if you will, due to hyperemia. And they found that if you look at a wide range of stenosis, that you got a scattergram of responses. This pathophysiologic index, coronary flow reserve, apparently had no real relationship with the percent diameter stenosis, and this was the best way of assessing stenosis using quantitative methods. If you notice here, some of the endpoints, some of the circles and squares are shaded. These are the patients that had abnormal scintigraphic studies, either thallium scintigraphy or a gated blood pool scintigraphy. And you can see that there is a striking correlation between abnormal coronary flow reserve and having an abnormal scintigraphic study. They also looked at a population of patients who had chest pain syndromes and turned out to have angiographically normal coronary vessels. The patients that had abnormal coronary flow reserve had the greatest incidence of abnormal scintigraphic studies, even though there was no detectable coronary lesion in the vessels. So these concepts are evolving. I think most would agree nowadays that pathophysiology is the primary determinant of a bad prognosis, bad endpoints in patients with coronary disease. This is a rather busy slide that's getting busier by the minute, and it looks at some of the current concepts of the pathophysiology of myocardial ischemia. Basically, the left side of the slide has indices of oxygen demand heart rate, wall tension, contractile state. The right side of the slide has indices of oxygen supply or coronary blood flow. With an imbalance in supply and demand, myocardial ischemia results. And some of the manifestations of myocardial ischemia are, of course, angina, chest pain, ECG abnormalities, metabolic abnormalities leading to abnormalities in function, and, of course, coronary perfusion becomes abnormal with myocardial ischemia. The non-invasive methods that we'll be talking about have their greatest role in detecting these endpoints, these results of myocardial ischemia. Probably the greatest amount of work to date has been done with stress testing, with the exercise treadmill test, using it as a predictor of high-risk anatomy. Among the EKG responses that are associated with high-risk coronary anatomy are early, deep, and prolonged ST segment depression, also downsloping ST segment depression. In addition, patients that develop malignant arrhythmias during exercise have a very high incidence of high-risk coronary anatomy. Some of the non-EKG indices that are associated with high-risk disease are the development of systolic hypotension during the treadmill test, indicating a drop in cardiac output, which is totally abnormal, a low achieved heart rate, blood pressure response, reduced exercise tolerance, and increased diastolic pressure. Now, among the scintigraphic indicators of high-risk coronary disease, more specific ones are reversibility in the distribution of multiple coronary vessels, indicating extensive ischemia, particularly when these reversible abnormalities occur at a low level of exercise and when these abnormalities show evidence of what's called delayed redistribution, and we'll talk more about that in a second. Some of the very sensitive indicators from scintigraphic studies of high-risk coronary disease are lung uptake, which is generally thought related to exercise-induced LV dysfunction, leading to increased end-diastolic pressure in the left ventricle, increased pressure in the lungs, greater lung water, and pulmonary extraction of thallium, cavitary dilatation, indicating failure of the ventricle with stress, most likely due to ischemia, and uptake at the base of the myocardium, which simply indicates that the rest of the myocardium is underperfused. Thallium scintigraphy has been around now for a good 12 to 13 years. And the early studies that came out in the late 70s were somewhat disappointing in that the overall sensitivity for detecting triple vessel and left main disease was not as high as people thought it would be. This slide is a summary of several papers that appeared in literature up to 79, and it showed that the ECG response, the marked ST segment depression, hypotension, etc., identified only about a third of the patients who had high-risk anatomy, triple vessel disease or left main disease. The scintigraphic abnormalities, and this is qualitative visual interpretation of thallium scintigraphy, did a little better, but not very much so. There was about a 44% sensitivity in detecting these two high-risk anatomic patterns. When the two were combined, sensitivity improved to 66%, but even this left a lot of patients unidentified who had abnormal arteriograms and multi-vessel disease. This led to further techniques to improve the accuracy of the scintigraphic methods in appreciating the full extent of coronary disease. This is a slide from a paper that came out around 1981 by Watson et al. In Charlottesville. And there are two different projections here in a patient who had an exercise thallium scintigraphy. There's an anterior view at the top initial image, repeat image at 1 hour, and another at 2 hours. And below is a 45-degree LAO image, initial to 2 hours. And I think you can readily appreciate this dense perfusion abnormality in the septum that improves over time. This is the typical scintigraphic appearance of reversible ischemia. What they found was that by looking at the kinetics of thallium in these hearts over time, they could diagram or pick out certain patterns. This aneroseptal defect had very low counts initially, but over time, as redistribution occurred, the segment showed an increase in the accumulation of thallium. This is reversible ischemia. Well, you can see that with your eye. You don't really need any type of curve analysis to let you know that there's something abnormal with the septum here. The high posterolateral wall showed a decrease in counts over time. It's hard to appreciate that visually, but the quantitative analysis showed a fall in thallium counts over the time interval. Now, the high posterolateral wall looks relatively normal, and if you were just reading this study in a qualitative manner, as was commonly done a few years ago, you'd say that this patient has a septal abnormality, the rest of the myocardium appears normal. But when you look at the quantitative assessment of thallium kinetics, you see that this high posterolateral wall actually increases its number of counts over time and remains relatively flat. So there's something different about the kinetics of this portion of the heart as opposed to the normal area of the heart. Same thing in the anterior view above. The inferior wall is abnormal and it gets better. Inferior defect, no problem. You can see it from the back of the room. What about the anterior lateral wall, though? Based on qualitative approaches to interpreting thallium scintigrams, you'd have to say that this patient has inferior ischemia. The anterior lateral wall appears well perfused at rest and remains so at redistribution. But if you look at the kinetics of thallium transport in this heart, you see that there's no evidence for a significant decrease in thallium counts over time. This assessment of thallium washout has proven to be a very useful means of enhancing our ability to detect the full extent of ischemic heart disease. Other groups have done other approaches to assessing washout of thallium. And this is a slide from a paper done by the group at Cedars-Sinai. Their approach is to look at the radial distribution of percent washout in various projections, and they compare this percent washout to a template derived from normal patients. And here's an example of an anterior view where the percent washout was below the normal range in multiple segments. I don't have the thallium image from this case, but the image looked totally normal. So here's a case with normal appearing image that had abnormal washout, and the patient had significant coronary disease. We've taken a slightly different approach to assessing thallium washout. We create functional images where we color code the percent washout. And by our convention, normal washout is from orange up to blue, and abnormal washout or wash-in is from yellow to green. These are two projections from a patient that had LAD disease and had a thallium treadmill, had ST depression and chest pain. And you can see evidence of abnormal washout in the region of the septum in these functional maps. This patient went to PTCA and had a subsequent study about 6 weeks after the intervention, and now you can see that the washout is pretty much homogeneous and normal. I should add that washout analysis hasn't really had much of an effect on the diagnostic utility of thallium scintigraphy, in that you still have a very high sensitivity in detecting the presence of coronary disease. Quantitative washout analysis hasn't done anything towards the diagnostic utility of detecting disease. Where its greatest role has been realized is in assessing the full extent of disease. This was studied in a systematic manner not too long ago, and it was found that the qualitative analysis of thallium identified multivessel disease in 75% of patients with two-vessel disease and in 82% of patients with triple-vessel disease. This is significantly better than the 44% sensitivity that was determined late in the 70s with a visual approach to thallium scintigraphy. In a more recent study from Cedars-Sinai, they too found that the addition of quantitative thallium imaging coupled with the responses that you get from treadmill testing, for instance, the blood pressure response and the ECG response, led to an overall 86% sensitivity in the detection of patients who had extensive coronary artery disease with a very reasonable specificity. Now, as I said before, the studies to date have all used coronary arteriography as the gold standard for determining what was significant and what was not. But there are some problems in looking at the anatomic approach. First of all, there is a lot of heterogeneity in various anatomic subgroups. Some patients with triple vessel disease have a poor prognosis, whereas other patients with triple vessel disease, appearing almost identical angiographically, have a fairly good prognosis. So it's now appreciated that pathophysiology plays a very important role in further subcategorizing anatomic subsets. This is one of Eli's favorite slides, and it says, is myocardial perfusion scintigraphy better than coronary angiography for coronary disease prognosis? The real endpoint, I think the most important information that we gain from these non-invasive studies is the ability to predict who's at risk for an event before it happens, not necessarily to correlate with what one may find at angiography. This is a report that appeared fairly recently where 268 patients were studied with thallium scintigraphy and angiography, and they were followed for 1 year without intervention, without coronary surgery. They found that by looking at the anatomic extent of disease, they were able to discern a twofold stratification in risk between single vessel disease and triple vessel disease. When they looked at the scintigraphic results in the same group of patients, they were able to get a stratification of 1.9% event rate in patients that had mild abnormalities, all the way up to 44% event rate in a year's time in patients that had severe scintigraphic abnormalities, a 20-fold stratification in risk based on the pathophysiologic markers provided by the non-invasive testing. In a separate study, this is from Cedars-Sinai also, it was found that the extent and the severity of perfusion abnormalities had a definite curvilinear relationship to the event rate. In other words, as the lesions are, or as the amount of ischemia is more extensive, and as the lesions or the perfusion abnormalities are more severe, there is a greater increase in event rate. They also found that if you look at the patients who have a very low achieved heart rate or a poor exercise capacity, that there is an even greater increase in event rate when you look at the severity and the extent of coronary artery involvement or ischemia. In a separate study, Gibson et al. Looked at 139 patients after a myocardial infarction. They did submaximal treadmill testing with thallium and angiography and had follow-up up to about 12 months. Of this 139 patients after an MI, 57 had cardiac events. And of the 57 with cardiac events, 86% had high-risk scintigraphic patterns, but only, should be an LY, only 68% of these patients with these hard cardiac events had evidence of multivessel disease. again supporting the fact that it's the underlying pathophysiology that carries the greatest prognostic information in predicting who's at risk for complications due to coronary disease. When looked at another way, they found that there was a much greater separation in low-risk and high-risk groups using the thallium scintigraphy as opposed to coronary angiography and treadmill ECG response. The converse is also true. This is a slide from a recent study that examined 345 patients with chest pain and a normal thallium scintigram. Follow-up over a year revealed very low event rates comparable to asymptomatic individuals and comparable to individuals who turn out to have normal coronary arteries at arteriography. So the scintigraphic indicators are very good means of determining who's at risk for major complications, and the converse, a normal scintigram in a patient who has a chest pain syndrome places that patient in a fairly low risk group and can allow conservative follow-up. There's a fairly recent development that's taking place now, and it's the use of pharmacologic stress testing. A fair number of our patients can't exercise for a number of reasons. It could be orthopedic problems, could be severe pulmonary complications limiting exercise capacity before the heart is stressed. It's been found now over the past several years that Pisantin or dipyridamole acts as a very good coronary vasodilator. It increases coronary blood flow roughly 4 times resting levels, which is comparable to the augmentation in flow that you would get with maximal exercise. This is our protocol. We infuse 0.14 milligrams per kilogram per minute of IV dipyridamole over 4 minutes, monitor the patient's hemodynamics. The peak effect generally occurs at about 7 minutes after the infusion has started, and we inject the thallium at that point. And we do the imaging in a manner that's similar to exercise thallium scintigraphy. This is an example from a patient that we studied a couple of years ago with dipyridamole. You can see the initial images above show a dense abnormality in the septum with near normalization at redistribution. Now, most of the time, these patients don't develop any chest pain, and they don't develop ST segment changes. So we can't say that they're having ischemia. In fact, most of the time they don't. What we're looking at is flow heterogeneity. There's increased coronary vasodilator reserve in the normal region and a blunted response in the abnormal region. About 10% of our patients develop chest pain. Recent studies have evaluated the prognostic utility of pharmacologic stress testing, and the results have been very encouraging. This is one study that appeared where the risk of peripheral vascular disease surgery was assessed preoperatively using dipyridamole thallium scintigraphy. These are patients who develop claudication and can't exercise very well. 54 patients were studied. 22 had evidence of thallium redistribution. 32 did not. Of the 22 with evidence of reversible perfusion abnormalities, 6 went to coronary angiography, and all 6 had multivessel disease and were treated upon aggressively. The 16 that didn't go to coronary angiography underwent surgery, and 50% of these patients had ischemic complications, pulmonary edema, death, etc. The 32 patients that had no evidence of reversible abnormalities on dipyridamole scintigraphy had no events during or following the surgery. In a separate study, Leppo et al. Looked at patients after an acute myocardial infarction with dipyridamole scintigraphy. They studied 51 patients, and they found interesting results. Of the 12 patients that died or had reinfarction, 11 showed evidence of reversible perfusion abnormalities with Pisantin thallium. The 24 patients that were readmitted with worsening angina, 22 of these 24 had perfusion abnormalities on dipyridamole. And the 15 patients that had no event all had negative centrograms. So it looks like the pharmacologic stress testing does offer very useful prognostic information in determining who's at risk for subsequent cardiac events in patients who can't exercise. I'd like to touch on one brief point at the end. There is a new development in scintigraphy, and that's the use of SPECT imaging, or tomographic imaging, in this case with thallium. It provides several distinct advantages over planar imaging. The target-to-background ratio is much higher, higher contrast, and it's possible now to avoid the problems of overlap of various segments that you often encounter in planar imaging. This is just an example of some of the different types of abnormalities you can find. These are short-axis cuts. This is an anterior wall abnormality, a lateral wall abnormality that gets better, an inferior wall abnormality that improves, and a patient with defects in multiple regions indicating multivessel disease. These images are much easier to interpret than the planar thallium studies. This is a case that we studied just a few weeks ago in the lab. It's a patient who had a history of an IMI and peripheral vascular disease who was to undergo surgery. And you can see that he's got evidence of extensive reversible perfusion abnormalities. So this patient was shunted to catheterization prior to surgery. And I'd like to finish with one point. The most recent development is the emergence of PET imaging to assess myocardial metabolism. In this patient that we just saw, there was a persistent defect at the inferior wall. Well, reports are now coming out to say that some patients with persistent thallium defects show evidence of viable metabolism indicating viable myocardium. Whether or not SPECT thallium will be accused of overdiagnosing infarct, that could be better clarified with PET imaging remains to be seen, but it's a very interesting concept that we'll hear more about in the future. I'd just like to end with this slide to say that ultimately we seek to identify and preserve the full extent of myocardium at ischemic risk. The greater the area affected, the greater the sum of reversible and scarred myocardium, the more aggressive the treatment should be. And conversely, if there is extensively scarred dysfunctional ventricles with little reversible ischemia, the treatment should be conservative. Thank you.